Imagine injecting a thick, water-absorbing gel into some of the most dynamic, highly pressurized tissue in the entire human body. Like, what stops that gel from acting like a squeezed water balloon and just shooting right back out of the needle hole?
Well, that is kind of the million-dollar mechanical question, right?
Yeah.
When you're dealing with a constantly moving, highly constrained biological environment, you can't just, patch a hole and expect the material to stay put.
Right. Welcome to the deep dive. If you're joining us today, you're probably someone who loves looking beneath the surface, trying to figure out the literal nuts and bolts, or, well, in this case, the fluids and tissues of how things actually work.
Yeah.
So today, we're taking a really thorough, highly detailed look at a topic that is fascinating, maybe a little unexpected, but completely rooted in fluid dynamics and human anatomy. We are talking about intimate hyaluronic acid, or HA, filler injections.
Specifically, we're looking at penile, labial, and G-spot augmentations.
Yeah. And we're approaching this with a very specific, highly mechanical mission today.
Right, because we are looking at the literal physics of these procedures.
Exactly, because our core mission today is to answer one central question for you. When a clinician injects a highly pressurized gel into these incredibly tense dynamic tissues, can this filler extrude or leak back out through the needle tract?
Yeah, and if so, how exactly do they physically seal the site? It's a massive mechanical dilemma.
It really is, and it requires some very clever clinical protocols to solve. To figure this out, we're pulling from a really diverse stack of sources today. We've got clinical protocols from the Sydney Royal Clinic and the Women's Health Clinic.
We also have peer-reviewed medical journals covering dermal fillers.
Right, and extensive clinical guides on vascular complications and, anatomical safety. Okay, let's unpack this. Before we can understand how this filler might leak out, we have to understand what exactly is being injected and where it's going.
That's the perfect place to start because, well, there's a huge public misconception about what hyaluronic acid actually is, starting with just the name itself.
Oh, yeah. I was actually reading the clinical perspective from Eurosculpt regarding that whole Olympic ski jumping controversy.
Right, the one where people were reacting to the word acid.
Exactly. The general public hears that and thinks it's some kind of corrosive, burning chemical being injected.
Which is chemically accurate in naming convention only,
Yeah.
but contextually, it is entirely misleading.
Yeah.
Hyaluronic acid is not a corrosive agent in the way we typically think of acid. It's a highly viscous hydrophilic, meaning water-binding gel.
Right.
And more importantly, it is a naturally occurring substance in the human body. I mean, it's the exact same material that lubricates your joints, keeps your skin hydrated, and, aids in wound healing.
So it's essentially a naturally occurring biological lubricant, like a shock absorber.
Exactly.
But for the procedures we're looking at today, they are placing this gel in very specific, highly targeted anatomical planes.
Right, because precision is everything in intimate aesthetics. If we look at penile girth enhancement, the clinical protocol dictates that the filler must be placed precisely in the subcutaneous layer.
Okay.
Specifically, it goes between the dartos fascia and buccal fascia.
Wait, let me stop you right there. For those of us who aren't urologists, what exactly is a fascia? Is it like a biological straitjacket? Because when I hear that, I just picture a rigid wall.
That is actually a really good way to visualize it. A fascia is a thin, very tight band of fibrous connective tissue. Think of it almost like the tough, translucent casing on a sausage.
Oh, wow. Okay.
It encloses muscles and organs to keep everything structurally sound. So when a clinician is injecting filler between the dartos fascia and buccal fascia, they're forcing a thick liquid into a potential space.
Right. A tiny gap between two very tight, unyielding biological straitjackets.
Precisely.
So that creates a tight, highly constrained space in male anatomy. But when clinicians move to female augmentations, like the labia or the G-spot, does the tissue tension change? Like, are they fighting that same heavily pressurized environment?
They are, but the anatomical targets require an entirely different approach. For labia majora augmentation, for instance, clinicians often follow something called the Isolane protocol.
Right, I saw that.
Yeah. Here, they're laying down up to 2 milliliters of filler per labium, and they place it in the subcutaneous or deep dermal plane.
And for the G-shot, or Grafenberg zone augmentation, the precision sounds even tighter. The sources state the target is exactly 2 to 3 centimeters from the urethral meatus. But urethral meatus.
That's simply the anatomical term for the external opening of the urethra where urine exits the body.
Got it.
So the clinician measures exactly 2 to 3 centimeters inside from that opening. But again, depth is the critical factor here. They have to inject the gel specifically into Halbin's fascia.
There's that word fascia again. So another tight layer.
Exactly. And they have to place it there while completely avoiding the superficial mucosal epithelium.
Which is the delicate surface layer of the vaginal wall, right?
Yes. But getting the filler into these tight spaces is only half the battle. The gel itself has to survive there.
Right, because I was trying to picture this. Imagine trying to build a bouncy castle inside a space that is constantly moving, stretching, and under immense physical friction. Because that is what coitus is, right? High friction, high shear stress.
Right.
So if this area is under so much pressure and movement, how does the filler not just, get flattened into a pancake permanently?
That brings us to a crucial chemical modification. The hyaluronic acid used in these specific fillers undergoes a process called BDDE cross-linking.
Yeah, I read about cross-linking in the journals, but the chemical diagrams were incredibly dense. What does that actually look like on a physical level?
Well, think of natural, uncross-linked hyaluronic acid like a bowl of loose spaghetti. The strands slide around each other easily. It's fluid. If you compress it, it just squishes outward. BDDE cross-linking is like taking microscopic chemical zip ties and tying all those spaghetti noodles together at various points.
Oh, so you turn a bowl of loose noodles into a tightly woven net.
Precisely. It alters the rheology, the flow properties of the gel, giving it a very high elasticity modulus, which physicists call G prime.
Right.
This cross-linking allows the gel to deform under intense pressure, like the friction of coitus, and then instantly bounce right back to its original shape.
Almost like a memory foam mattress.
Exactly like that.
That makes perfect sense. But looking at our main mechanical problem for today, the extrusion dilemma, it seems like that exact resilience is a double-edged sword. If it resists being flattened, it's going to fight back against the tissue.
Well, if we connect this to the bigger picture,
Yeah.
you've just identified the core mechanical risk.
Right.
You have a highly pressurized viscous gel that fights to hold its shape, being pumped into a confined anatomical space that already has immensely high natural tissue tension.
Yeah, I read the term submucosal tissue turgor in the clinic notes from the Women's Health Clinic, especially regarding premenopausal women. But I couldn't quite picture what that actually means for the needle entering the tissue.
Think of tissue turgor like the air pressure inside a fully inflated car tire.
Okay.
In premenopausal women, estrogen levels keep the vaginal tissues highly vascular, thick, and very firm. The turgor is high. So when you push a needle into that tissue, the tissue is squeezing tightly against the needle shaft the entire time.
So the immediate physical consequence of pushing this gel in and then pulling the needle out is that the filler is going to take the path of least resistance. It's going to want to shoot right back out of the tunnel you just created.
Along with a fair amount of blood, yes. And remember, hyaluronic acid is hydrophilic.
It pulls in water.
Exactly. The moment it enters the tissue, it starts aggressively pulling in surrounding water, expanding over the first 48 hours. This creates even more outward pressure pushing back against the entry hole.
Wait, this is the part that really caught my attention in the clinical protocols. You're telling me they pump a highly viscous gel into a dense, heavily vascular area like the anterior venous plexus under high pressure.
Yeah.
And the primary clinical mechanism to plug the hole and stop it from leaking out is just inserting a tampon for 4 hours. How does that physically work? It sounds way too simple to hold back that much pressure.
I know, it does sound surprisingly low-tech compared to the chemistry of the filler.
Yeah.
But it relies on the fundamental physics of tissue tension and counterpressure. According to the Sydney Royal Clinic protocol, inserting that tampon immediately after the needle is removed provides direct, sustained mechanical counterpressure against the vaginal wall.
Let me get this straight. So the tissue is trying to squeeze the gel out horizontally through the needle tract, but the tampon pushes vertically against the wall, essentially flattening the tunnel.
That is exactly the mechanism. By flattening and collapsing that needle tract, you eliminate the path of least resistance.
Wow.
Yeah, and the tampon stays in for 4 hours because that is the critical window for initial coagulation and fluid settling. It stops the immediate release of blood, blocks the filler from refluxing out, and physically forces the HA gel to begin integrating horizontally into the surrounding extracellular matrix.
Rather than just squeezing vertically back out the hole.
Exactly.
Okay, that makes a lot more sense now. The sources also mention a strict post-injection compression protocol for the labia and penile procedures. Clinicians apply firm manual pressure to the area to minimize that immediate swelling and stop any minor capillary oozing.
Right. It's all about managing the physical pressure differentials.
And managing depth is just as crucial as managing pressure to prevent mechanical complications, right? Take the G-shot, for example. The clinician uses a two-finger transvaginal check during the injection.
Yes.
What are they feeling for exactly?
They're palpating the area in real time to confirm the filler is sitting in the correct, shallow submucosal space. Because if they push the needle too deeply, they bypass the fascia entirely and hit the periurethral smooth muscle.
And what happens if the gel ends up in the muscle?
Well, the clinician will notice immediate visual and tactile signs. The tissue won't project outward correctly. But more dangerously, depositing a thick, expanding gel into that deep muscle layer creates a severe risk of urethral compression.
Oh, no.
Yeah. The gel can physically pinch the urethra closed from the outside, leading to acute urinary retention.
Here's where it gets really interesting, though. We've been talking about the pressure forcing the filler out of the body through the needle tract, but the sources detail another terrifying risk of pressure. What happens when that pressure causes a mechanical failure during the injection, inside the device itself?
Ah, you're referring to a syringe explosion.
Yeah. Think of it this way. It's like putting your thumb over a garden hose when it's on maximum pressure. If the water can't go forward, it's going to blow the nozzle right off the hose.
Right.
Or in this case, the immense hydraulic pressure blows the needle right off the syringe.
BD Medical Systems provided some fascinating data on the physics behind this. Because HA dermal fillers are so thick and viscous, it requires a substantial amount of physical force from the clinician's thumb to push the gel through a tiny 27-gauge or 30-gauge needle.
And all that thumb force hits a single weak point, right? The lure lock adapter. That's the little plastic threading mechanism that twists and locks the needle onto the barrel of the syringe.
Correct. If there is a sudden blockage in the tissue, or if the clinician pushes just a fraction too hard, the hydraulic pressure inside the barrel overcomes the plastic threading of the lure lock.
Wow.
Yeah, the adapter can rotate, disconnect, or literally rupture under the strain, spraying filler everywhere.
The clinic guides say if a syringe explodes, you have to stop immediately, discard the entire setup, and start over with a completely fresh syringe because it's a massive breach of sterility.
Exactly.
And the clinician suddenly has zero idea how much product actually made it into the patient versus how much is on their gloves.
But an exploding syringe, as messy as it is actually the lesser of two evils when we talk about pressure complications.
Oh, absolutely.
The big one, the one that absolutely keeps clinicians up at night, is vascular occlusion.
This is where the gel stops blood flow entirely.
Yes. It is the most severe risk in any dermal filler procedure, and it happens in one of two ways. The first is intravascular emboli. This means the sharp tip of the needle accidentally pierced directly into a blood vessel, and the clinician injected the thick gel inside the vein or artery, causing a physical blockage.
Right.
The second way is extravascular compression.
Extravascular meaning outside the vessel, so you inject so much filler into a tiny, tight space that the outward pressure of the gel just pinches the adjacent blood vessel completely shut from the outside.
Exactly. The pressure in the tissue exceeds the pressure pumping blood through the vessel, collapsing it. Either way, blood flow stops. And if blood flow stops, the tissue is starved of oxygen and begins to die.
That is necrosis.
Yes. In facial filler applications, severe occlusions have even led to permanent blindness.
The warning signs the sources list are immediate. The clinician will see skin blanching, where the tissue turns stark, ghostly white as the blood is forced out of it.
Right.
This is often followed by a livedo pattern, which is a purplish, mottled, net-like discoloration on the skin, accompanied by sudden, disproportionate pain.
Which brings up the crucial question of how clinicians prevent this from happening in the first place.
Yes.
The sources mention a very intense debate in the medical community around something called the aspiration protocol.
Right. Traditionally, I read that clinicians are taught to aspirate. They position the needle in the tissue, pull back on the plunger, and hold it completely still for about 5 seconds.
Exactly.
If they see a flash of blood enter the syringe hub, they know they are sitting inside a blood vessel and they abort the injection.
But the literature from the PMC journal highlights a major mechanical flaw with this traditional thinking. Because holding a needle perfectly still in soft, highly dynamic tissue for a full 5 seconds is incredibly difficult.
Right. Because the patient breathes or the clinician's hand shifts.
Exactly. The moment you push your thumb forward to actually inject after pulling back,
Hmm.
you might millimeter shift the sharp tip of the needle right into a vessel anyway.
Oh, wow.
Furthermore, HA is so thick that sometimes pulling back doesn't even generate enough vacuum to draw blood, creating a false negative even if you're inside a vein.
That's terrifying.
It is. So some experts advocate for the exact opposite approach. They say,
Hmm.
never hold still. Keep the needle constantly moving back and forth through the tissue while injecting.
Hold on, I have to push back on that. Isn't constant movement vastly riskier? If you're moving a sharp needle around blindly in a highly vascular area like the labia or penis, aren't you going to slice into way more vessels?
It sounds counterintuitive, but the defense of the constant movement theory relies on the concept of volume. If you hold still, you might deposit a massive vessel-blocking bolus of gel into one spot.
Okay.
If you are constantly moving back and forth and you accidentally pass through a vessel, the speed of the movement means you'll only leave a microscopic fraction of a droplet inside the vessel.
Ah, I see. An amount so small that it just dissipates harmlessly in the bloodstream rather than causing a massive blockage.
Exactly.
Yeah.
But this debate over moving sharp needles through tissue brings up perhaps the most effective safety tool they have, the cannula.
Right.
We mentioned it briefly regarding the E-Lane protocol, but we really need to emphasize why blunt-tip microcannulas like a 22, 25, or 27 gauge are rapidly replacing sharp needles in these high-risk, intimate areas.
I assume it has to do with how they interact with the blood vessels. A sharp needle is going to slice through whatever is in its path, right? Like a tiny scalpel.
Yes, but a blunt-tip cannula is rounded at the end. Blood vessels are naturally elastic and resilient. So when a rounded cannula encounters a blood vessel, instead of piercing it, the cannula tends to simply push the elastic vessel gently aside.
Oh, that's so smart.
It displaces the tissue rather than slicing it, which drastically reduces the physical risk of an intravascular injection.
Okay, so despite using cannulas and aspiration and counter-pressure tampons, let's say the absolute worst happens. A vessel is occluded and the tissue is turning white. Or let's say the patient simply develops awful, painful lumps, which the literature calls granulomas.
Right.
With all these mechanical risks, extrusion, explosions, occlusions, why is hyaluronic acid still considered the absolute gold standard for intimate injections?
Because HA possesses a biological failsafe that no other filler has. It has an undo button.
Hyaluronidase.
Yes, hyaluronidase is an enzyme. And what is brilliant about this is that the human body already naturally produces it.
Really?
Yeah, it is an enzyme specifically designed by nature to cleave the chemical bonds of hyaluronic acid. In an emergency like a vascular occlusion or a severe granuloma, clinicians can inject a highly concentrated dose of this enzyme directly into the problem area.
And it literally dissolves the cross-linked filler net, turning it back into a liquid that the body absorbs within hours. It restores blood flow, saves the dying tissue, and gets rid of the lumps.
It is the ultimate safety net. And understanding this safety net is exactly why the medical literature across all our sources is so vehemently against using permanent fillers in these sensitive regions.
Yes, the Urosculpt and Clinica NEF guides were incredibly clear on this. They specifically call out materials like PMMA, liquid silicone, or polyacrylamide gel.
Those materials cannot be dissolved. They are permanent synthetic plastics. If a permanent filler causes extravascular compression, or if the immune system attacks it and forms severe encapsulated granulomas, there is no enzyme injection to fix it.
So for you, the listener, if you are ever researching these procedures or if you ever find yourself sitting in a clinic chair looking at a brochure, the phrase permanent filler should be a massive blinking red flag.
Absolutely.
If things go wrong, you are looking at complex, invasive surgical removal, and cutting permanent plastic out of delicate tissues like penile skin or the vulva often leaves severe permanent deformities.
Furthermore, permanent fillers don't age with the body. As your natural intimate tissues change over the decades, losing elasticity and volume, a permanent filler remains completely static.
Which would look terrible eventually.
Yeah, this often leads to bizarre, unnatural structural results 20 years down the line. In these highly dynamic, friction-heavy intimate zones, you absolutely want something reversible.
You want hyaluronic acid. Because even if everything goes perfectly and the filler stays exactly where it should, HA undergoes a natural, predictable degradation over 6 to 24 months. Your body's native hyaluronidase just slowly and naturally breaks it down.
And what's fascinating here is that degradation timeline isn't arbitrary. The Women's Health Clinic sources point out that the rate of breakdown is dictated by the native environment it sits in.
Okay, meaning what?
The 37 degrees Celsius body temperature, the natural vaginal or local pH levels, and going all the way back to our earlier point about the bouncy castle, the intense mechanical shear stress of coitus. All of these factors actively work to metabolize the gel over time.
So it integrates horizontally, holds its ground against the pressure, and then gracefully exits over time. Let's take a step back and recap this journey, because the mechanical ingenuity required to make this work is wild.
It really is.
We started with a hydrophilic cross-linked gel that acts like a biological memory foam. We looked at the surprisingly simple physics of using a tampon to provide vertical counterpressure to stop the gel from extruding back out the needle hole.
We examined the intense hydraulic pressure dynamics inside the luer lock of the syringe, the terrifying risk of vascular occlusion, and how blunt-tip cannulas use displacement instead of slicing to mitigate that risk.
And finally, we landed on the biological safety net, the hyaluronidase enzyme that makes this whole high-stakes procedure uniquely reversible.
But if we are talking about hyaluronidase, there's one final, unaddressed concept from the medical literature that I want to leave you with, because it highlights just how unpredictable the body can be.
Yay. What's that?
We mentioned that your body produces native hyaluronidase to slowly break the filler down over a year or two. But clinical studies show that localized hyaluronidase activity can aggressively spike during systemic inflammatory states.
Wait, meaning if you catch a bad strain of the flu or if you get a severe systemic infection?
Exactly. If you get sick, your immune system goes into overdrive. And when it does, your body might suddenly decide to dissolve your intimate filler at a vastly accelerated rate, entirely on its own.
You're kidding.
Nope. A procedure meant to last 18 months could significantly degrade in a matter of weeks, just because your body mounted a massive immune response to a completely unrelated virus.
Wow. It just goes to show you, no matter how much we try to approach the human body like a simple engineering problem, calculating pressures, collapsing needle tracts, and using enzymes to patch holes, biology is always in control. It's a dynamic, living system, and it will always have the final say.
Well said.
Thank you for joining us on this deep dive. Keep asking questions, keep looking beneath the surface, and we'll see you next time.